So Geraldine asked me to talk about the natural history, right? And I think one thing that's for sure, it's a wonderful conference, and it's amazing to see how much it's grown, and not just in terms of the participation. And I think this is actually a particularly cool format, but also in terms of our knowledge, right? We've learned a lot over the last 8 years, and so even though it may feel a little bit like the theme from yesterday and this morning in terms of the scientific talks are a lot of we don't knows, with the exception perhaps about the genetics. And then, I think it gets a little frustrating to hear all of this characterization. Okay, so these are the descriptions, and this is what we know is happening for these kids, but we really don't know what the rates are. We don't know how to compare this to other kids with developmental delays, and we don't really know what to do about it. And that's the frustrating part. And unfortunately, with respect to natural history, I'm not sure it's going to be that much different. So Geraldine asked me to talk about the natural history, and this is a critical area. So I think part of my task is going to try to convince you why it's so critical. But again, there's a lot that we don't know, and it's a big priority for us to try to figure out what the development of PMS looks like over the lifespan. But it's a very, very challenging thing to really nail down. So that's my kind of intro comment. And then you've been hearing a lot about this RDCRN, so our Rare Disease Network. And this has been a really fantastic opportunity that I think we all feel really privileged to be a part of. And so I know it's been kind of mentioned a few times. I did want to tell you just broadly what our overarching goals are, because it is called a natural history study, and that's actually the critical component. So the first is that we need to get a better understanding in a very prospective, more objective way about what the features are. What are the medical features? What are the psychiatric features? Cognitive, language, all these different elements have been surveyed across many studies, and people like Katie Phelan have done a wonderful job trying to help us understand the phenotype. But most of the studies have relied a lot on retrospective recall, parent surveys, and not as much on really kind of observing children in the moment using more standardized instruments. And that's kind of what we want to be doing now. We want to be looking forward to try to figure out what the prevalence of these kinds of problems are, but doing it with more standardized measures. And then we want to know, how does the syndrome change over time? And that's, I guess, the topic that I'm supposed to be talking about. And that's really important for a variety of reasons that I'll go into, but how do you do that is the question, right? Do you ask parents, what was your child like at 3 or 4 or 5 or 12? Or do you actually try to follow them at different time points? See a child at 3, and then again at 5, and then again at 7? Or do you, and Joe sort of mentioned this a little bit yesterday, or do you just take a group of kids and see them at, between 12 and 15, and another group between 21 and 25? So there's a lot of challenges with this. So that's what this talk will focus on. And then I think Paul maybe who said yesterday that it's not particularly interesting to families, things like biological markers, right? What's electrophysiology mean to me, really? Why are EEG measures important? Do I really care how my child's brain responds in terms of visual stimuli or auditory stimuli? But for us, it is important, actually. It's important partly because it reflects electrical activity of the brain, for example, but it's also important because it really helps us think carefully about how do you design trials. And that is, I think, maybe my biggest take-home, is that what we're all most interested in, and I think what you're all most interested in, is how do we do a better job of treating these kids? And in order to treat these kids, you need to do clinical trials. You need to do clinical trials with medicines. You need to do clinical trials with speech therapies and behavioral therapies and occupational, all these kinds of things. You actually have to study it in a systematic way in order to know that it works. It's extremely valuable to get information from families about this worked and that worked from my child or my 10 children. But as a population, you really need to do it in a systematic way and compare it to either an established therapy or placebo, nothing. So really our work in looking at different biological markers, whether it's using neuroimaging or visual evoked potentials or auditory evoked potentials, these are all the kind of fancy things that feel very sort of distant from what's clinically relevant for your child, actually will become clinically relevant for your child, I promise. And then the other thing that's really interesting to us, and that's part of our overarching aims, is where else in the genome is impacting the phenotype, right? So we talk a lot about this idea of severity, and whether the size of the deletion is important for the severity of the phenotype. And Luigi just got this award for his poster, and I think we're all really interested in this area. As Joe mentioned yesterday, it's a very, very challenging thing to do with small samples of patients, and even 100 patients, frankly, in this case, is a small sample of patients. We see kids with very small deletions who are severely affected, and we see kids with very large deletions who are not severely affected. So this question of, are there other genes in the region of 22q, or are there other genes across the entire genome that have an impact, either protective or contributing to the severity? That's something that really we need to figure out. And so as part of these studies, we're doing whole exome sequencing, and we're doing expression analyses, and we're doing all kinds of things to try to nail this down. And Joe has a nice poster. We put a nice poster together, kind of taking a very small step towards this idea of identifying, resilience factors. So our consortium is set up across 6 sites. And Matt, you heard from yesterday. Matt's our 7th site. I'd like to call it Kansas our 7th site. So he started with Craig at UT Southwestern, moved to Kansas, and we're continuing to kind of rein him in, and he's involved now in some of the electrophysiology studies. In fact, some that are also supported by the Phelan-McDermid Neuro Foundation. But you heard from Latva, from Audrey at NIH. Craig is here, and John is here also from Stanford. And this has just been a great group to work with, and we're killing it in terms of trying to recruit families, and you guys are killing it in terms of participating. It's been remarkable. We have these calls every month with the NIH because they're very involved in this study. And in terms of recruitment numbers, we're doing phenomenally well. And it's just terrific. Yeah. You can give yourselves a round of applause, yeah. And then somebody else mentioned something kind of related, which is that whether the NIH is continuing to see patients. And the NIH is continuing to see patients, just so you know. They've been, phenomenal. They've recruited already 3 times, literally 3 times the amount of patients, I think 15, 16 patients, more than they were signed up to do. And so they're kind of, collecting their thoughts, and they're making sure that they're taking good care of the patients that they're seeing, but they're going to continue to see patients because they obviously have enormous amounts of expertise that are super valuable, and they have a real complementary set that I think we could all benefit from. So they are continuing. So do not despair. And they have really nice facilities. Right, Audrey? Audrey, anything else about that? Yeah, okay, she's happy that I said that. Okay. Okay, so natural history. So when Geraldine asked me to talk about this, I thought, oh gosh, 20 minutes on the natural history? That's going to be really tough. But I'm already 10 minutes in, so I guess we'll be fine. So why is natural history important? And going back to my first comment, we're all about developing treatments, okay? And so in order to develop treatments, it doesn't matter what the treatment is, we need to understand what the symptoms are. What are the issues? Do you want to start developing a treatment for cyclical vomiting, or it only affects 10% of the kids? Obviously, that's a very important area, but that's probably not where we're going to start. So what's common across these kids, right? Motor skill deficits, that's very common. Language deficits, that's common, right? Intellectual disability, that's common. So those are the kinds of things that we want to start thinking about targeting because it affects the broadest kind of amount of people, right? And so those are the targets. That's when we talk about therapeutic interventions, we talk about targets. And we need to be able to really understand what the diversity is of those kinds of deficits. And again, this is all about building the foundation for trials. If we look at natural history and we see that actually there's a lot of change over time in motor skill deficits or in language, that may not be the ideal target for a clinical trial. Or if it is a target for a clinical trial, we want to make sure that the population that we select to do those trials in is actually very narrow, because if it's a moving target, it's very hard to see change over time. Or if you're going to see change over time, which you would expect to, it's very hard to show a difference between medicine or any kind of intervention and placebo, which is what we have to do as a gold standard to establish that medicines actually work, or anything works for that matter. Other things that are important to try to figure out are, what are the other variables that contribute, right? We hear a lot about different things that go on in the environment that perhaps change the way that symptoms present. Do children switch between, one facility to another facility? Do they go from home to a residential facility? Do seizures start to occur? Are they going through puberty? These are all variables that we don't know a lot about, but it would be very helpful to understand in order to predict the course. When do we really want to be very vigilant, for example, about the emergence of seizures? We don't know the answer to that yet, but natural history studies will establish that. And then, of course, this is what we'll all be talking about, best clinical practices. So what's a really good evaluation? What do those evaluations include? Do we want to be doing everything in everybody? Maybe, but maybe not. And again, trying to understand the sort of breadth of the phenotype and how it evolves over time is critical for all these factors. Okay, so before I go to the next slide, so then I mentioned this a little bit. So how do you figure out this natural history question? And historically, it's been done by asking parents, what was your child like when they were 4 or 5 or 9? And this is really valuable, and this is an important piece of the information, but it's not all of it. So when I was training, I had a mentor in pediatrics who used to tell me, if you just listen to the patient, they will tell you the diagnosis. And that's what we do. We listen to patients, we listen to parents. This is critical. This is the most critical thing. But it's not the only thing, and I think it's really important to understand that we all bring a lot of bias into our understanding about these children. The clinicians do, the parents do. I mean, it can have so much of a difference if you've got another child who's either typically developing or not typically developing in terms of your reference point. And so Kathy Lord in autism sort of broadly, this is not Phelan-McDermid syndrome, has done a lot of work looking at this question of regression. And so I put this up here just to kind of give us a little bit of a sense that we're not so great, actually, at looking back and thinking about when symptoms started or didn't start, or when they got worse or when they got better. And in fact, if you take parents and you ask them when were their children's first words, if the child at the time was 2 years old, they'll tell you a certain date. And then you ask that same exact parent when the child is 5 years old, when was your child's first words? This is the same kid and the same parent, and all of a sudden that date becomes later and later and later and later, depending on how old the child is. So it's kind of interesting, right? I'm not saying that parents can't be relied on. I'm just saying that your perspective changes over time. And so it's very hard for us to say, okay, there was a regression when actually it's the same child and it's just a sort of a recall effect. Does that make sense? Yeah. And so by the same token, you can ask parents when the child's 5 years old, what are your symptoms like right now? And then if you fast forward and 5 years later, you ask the same parent about their child's symptoms when the child was 5 years old, they actually describe the symptoms in more severe terms. So how you ask the questions makes a difference. In fact, this same study that I'm putting up here, I think one of the things that the point that they made was that you sort of anchor, we all do this, we kind of anchor our current reporting, or rather we anchor our past reporting in our child's current symptoms. And so the severity can vary based on, are you asking about symptoms of the present first, or are you asking about a history of symptoms first? Those things make a big difference. And in my experience, if you have another child and you see that child developing, that makes a big difference. So these are all, really important factors. So for us, actually the best way to do this is to just directly evaluate the child at multiple time points, and to kind of focus on the present, and sort of do cognitive testing and language testing, and then do it at repeated intervals over time. This is challenging to do, obviously, and we'll talk about some of those challenges in the discussion, hopefully. But just to give you a sense of what we are doing, this is a 5-year grant, this rare disease network. So we're looking at children at baseline, then we're seeing them at 1 year, and then a 2-year follow-up. Yeah, and frankly, if the child is 2 when we start, or rather, I think this study begins at 3. The child's 3 when we start. There's a big difference between 3, 4, and 5, and 20, 21, 22, in terms of how much growth you would expect or not expect. So these are all kinds of issues. But we're going to be seeing people over multiple time points. And hopefully I've convinced you that this idea of natural history is really important, because I know that for families it's extremely frustrating to come back year over year over year, especially if you don't think that things have changed. Really, what's the added value in going back and getting the same round of assessments over and over again? But we encourage you to do it because it's going to help us a lot. And I think it's going to help the field a lot. And so this is what we're doing in general. These top kind of, is that the bell? Oh my goodness. The natural history of my, that's so funny because Matt said the same thing yesterday. I thought I have to just like keep squeezing stuff out. All right, so this is our assessment. Does it give me 1 minute, Caroline? 1 minute, holy cow. And so some of these assessments clearly are things that you do not need to repeat over time. I mean, for the most part, the cardiac problems that we see in Phelan-McDermid syndrome and the kidney problems, these are congenital problems. And so that if your child is not born with a congenital kidney problem, you don't need to keep checking it over and over again. If, however, your child is born with some sort of congenital kidney problem, then it's critical to keep checking, but make sure there's not progress there. We're doing a lot of cognitive assessments, language assessments, behavioral assessments. We've spent a lot of time thinking about what the best kinds of assessments are. You've heard about the challenges in trying to assess kids with significant developmental delays. We don't have great instruments to do that. So we've picked sort of a swath across a lot of different domains to try to capture it. Oh my goodness, this is terrible because now I've got more stuff to talk about. So maybe I'm going to eat into some of our panel time. How about that? All right, I got 2 minutes. So I did a literature review, and I managed to identify about, I think, 19 cases of this idea of a change in phenotype or regression. And then I talked to Catalina Betancourt, and of course she'd identified double that. You should laugh, because it is actually funny. Where's Catalina? Yeah, she identified double it. She has this way of finding things that, or even finding things in my own papers that I forgot. So there have been, according to Catalina, about 32 cases in the literature that have been described with some change in the phenotype. And it's mixed between males and females. It's about the same. I would say that the kinds of chromosomal rearrangements, it's across the board. So you can have deletions, you can have ring chromosomes, you can have small mutations. So this kind of change can affect virtually any type of deletion or chromosomal rearrangement. It seemed to me from the review that the average age was around late adolescence, but if you looked at the actual studies, it was around 23 years old. And it also seems to be that the most common change that's occurring is a psychiatric one where kids are sort of developing a mood cycling disorder, or what in literature is described as atypical bipolar disorder. And it's atypical because it's not following a pattern that is classically described in the diagnostic manual in psychiatry. And in fact, when you think about psychiatric comorbidity in Phelan-McDermid syndrome, you can basically throw out the diagnostic manual because it's irrelevant, right? You can't ask kids about feelings of sort of euphoria. You have to base it on your observation. So this is a really imperfect way to describe it, but the ups and downs of mood. And I'm going to give you one description, or actually this is 2 patients, that seem to, for me anyway, capture the themes that I was hearing in the literature. So these were 2 patients with tiny little mutations affecting only SHANK3. So the SHANK3 protein was not being translated. And these were kids who, in adolescence, had some shift in their setting. And frankly, it wasn't even clear to me what this shift meant, but this is what was written in the papers. So they went from an autism unit to a different unit. So just the novelty, just the change in your environment is obviously going to have a big impact. And that's true across developmental disabilities in general. These were kids who at baseline, this is just 2 kids again, but it's sort of representative of the larger sample. They did have words. They had some very basic communication capacity. But their change began with this loss of language. So there was a real cognitive change, a real language change. Their self-help skills changed, so they were able to they were toilet trained, it seemed, at baseline, and they had lost the ability, so they became incontinent. There was a lot of psychiatric stuff like impulsivity and aggression. And then this is also kind of key, this description of apathy, where they became kind of withdrawn, they stopped caring about their environment, or are you coming close to me because you're kicking me off this? All right. And then this idea of catatonia, where they would get kind of stiff or non-responsive, right? Importantly, neither one of these patients had seizures, and neither one of these patients had any significant structural abnormalities in their brain, right? Many different medications were tried, and this is true, I think, across the community. For the most part, I don't think families feel as if medicine has been particularly helpful. That's generally true in the literature. Among the classes of medications that seem to be more helpful, at least for this kind of phenotypic change, are what are considered to be mood stabilizers or anti-seizure types of medicines, or in these two cases, lithium. Lithium's been talked about a lot, and it seems to have benefit, at least in these two cases, because they both these kids reverted to baseline. Again, developmentally delayed, intellectually disabled at baseline, but that loss of continence and the self-help skill, all these kinds of things that had dramatically shifted, returned, which was a good thing with lithium. Okay, I mean, what am I going to do? You're kicking me out.
I personally want you to keep talking, but I know that this is kind of this topic generally of regression and kind of what happens as people age is really important to you guys. So I think we need to go ahead and proceed with the discussion. But I may send Alex over to that back corner to talk with some of those families.
Okay. All right.
I am Rashmi Gopal Srivastava from the Office of Rare Diseases Research, National Center for Advancing Translational Sciences, or NCATS, within NIH. I did have a few slides, but that's okay. And you have been hearing about RDCRN, or Rare Diseases Clinical Research Network Program. I oversee this national program within NCATS, which is the newest center within NIH. And there are 22 multi-site consortia and a central data management and coordinating center. And one of the 22 multi-site consortium is on developmental synaptopathies, which is led by Dr. Mustafa Sahin. And there are 3 rare diseases being studied within this consortium, and PMS is one of them. And the focus of this program, RDCRN, is on natural history studies, and along with training of young investigators and pilot projects. And the unique part of this program, this is the only program at NIH, even though this initiative is from NCATS, is that we have made it mandatory for all good reasons that the PIs, principal investigators, the physician researchers, and their multidisciplinary team, they partner with patient advocacy group. As you know, we cannot do without the patients and the patient advocacy group, so we are very thankful for this partnership. I would also like to take this opportunity and thank the organizers of this symposium, specifically Geraldine, for giving me this opportunity to come here and moderate this session. I'm extremely delighted and excited, and I've learned a lot of new things, and I'm anxious to learn a few more things. And you just heard a great talk from Dr. Kolevzon on natural history studies. And these studies, NHS for short, are essential to understand the pathogenesis of disease, how the disease progresses. And you also heard that NHAs are important, and they are helpful in understanding the disease progression, in predicting disease outcomes, and developing targets and biomarkers for future treatments. And I'm also very happy and excited to see that several members of RDCRN are here, including our excellent panelists, Dr. Kolevzon, Dr. Surya, and Dr. Thurn, and many more in the audience, including Geraldine and Megan O'Boyle. So without taking further time, I would like to open this panel discussion. And I'm going to look for if I have any questions. I was told I should receive it on my email. And so I think we'll go ahead and look at the challenges and hear from the panelists, your thoughts about the challenges which were on the last slide I saw. Challenges for discussion, these are the points. The measure, and I'm thinking these are outcome measures. And the second one is design, including ages of patients, cross-sectional perspective, and may I add retrospective too. And then the time points, and also the feasibility, including costs, and the 5-year grant cycle was also mentioned. So maybe start with Dr. Kolevzon.
Thank you. Let's see. Well, I mean, this is stuff that the three of us talk about often. I don't know. I'm curious about the family's input, frankly, and just to frame it a little bit. So, The NIH gives you money to do a grant. They say you have to do the whole thing in 5 years. We're not going to guarantee you another 5 years after that. And then our task is to try to understand how does Phelan-McDermid syndrome develop over time. And so the first question that we're asked is, okay, so what kids do you want to study? How old should those kids be? And so from our perspective, you want to study the smallest possible kids as early as you can, and you want to study the oldest possible people as late as you can. But you also need to have a battery of assessments that are relevant to all those different ages, which gets very complicated. And then you have to study the natural history, which means what? Every 5 years you see kids? Every 6 months you see kids? You know, how quickly do you expect things to change over time, and what can you do in the context of a 5-year grant? So I'm sort of throwing all those things out there just to help people understand the challenges. So yeah, when we say measures, we talk about what's relevant to this population, what do we think really captures the phenotype. When we say, you know, time points, every year, every 6 months, every 5 years. What else? Latha's going to talk now.
No, I think I mean, I wouldn't add anything and would agree with that. All of that. I think what we've learned maybe from some of the challenges is where maybe we need to, where we could tweak our approach. Whether it's hard to do that within the context of a funded trial, and to change midway is difficult. But you know, even looking, we're just starting our first set of 6-month follow-ups. And finding that there are challenges in how we're assessing progression and regression within domains. And as a sort of network, starting to be able to start to talk about that and whether we get funded again or not, you know, these would all be considerations, I think, as we're going through the challenges.
Yeah, I just want to talk a little bit about the assessments that we're actually doing, and just put them into context, because a mom yesterday said, you know, my child is verbal, so they could do X, Y, and Z, but I'm sure a lot of the other kids in the study might not be able to do all the tests. So one thing to know is that the way this is set up based on NCATs is that there are 3 disorders being studied, and in this case the other ones are P10 and tuberous sclerosis. But it could be other disorders as well. But the first thing that we need to do in a natural history study is really put each disorder into context of other, in this case, rare disorders associated with intellectual disability and autism. So we take sort of the tests that we have been used historically in other things, and we need to kind of start from there and using those tests, even if they're not really appropriate for this group, because the only way we can put this disorder and the characterization of the phenotype here into context with others is by doing the same tests. But I think we know that there's frustration from families and the children themselves in going through some of these tests that are not very appropriate. But it's been enormously helpful in helping us now think about how we can develop new and different tests that are more appropriate. But we need to start from what exists and work from there. And the natural history study is a hard place also to develop new things, because we need to try to do the same test over time to make sure that we're seeing the stability and the change. So this is just, especially as the families are now going to be entering the 2nd and 3rd year, some of them, just a plea for patience with us, because we know that there's huge limitations in what we're doing.
I just, as one add-on to that, you know, we also know that kids can sometimes do things at home that they can't do with us in the lab. So we appreciate that. That's something I hear a lot from parents, that our measure of cognition is fundamentally flawed, and we acknowledge that. You know, the way that children perform and adults perform on these tests depends on how much they slept, whether they ate, the fact that they just took a flight perhaps to see us, that they're sleeping in a strange place. So we get all of that. And that's actually another reason why it's important to have a lot of different time points and have a lot of different kids involved, because you know, the larger the sample, the more that kind of variability ends up becoming less and less important.
Thank you. So we do have some questions, so I'm going to pose the first one. Can the panelists discuss upcoming studies and natural history studies? My table is 2 to 4 years old table, which are almost at the age minimum. So they are interested in design and direction of future studies.
So
Yeah,
I think we'll
please.
all talk about some of the studies that we're interested in. So our site at Mounts, and we all have a lot of different interests, I think, and some of the studies are collaborative projects, and some of them are unique to specific sites. But so one very big project for us is to try to develop these biological markers. So we're very interested in electrical activity of the brain and how that activity changes in response to visual or auditory stimuli. We think that's going to help us understand the physiology, and also it'll give us a way to measure change over time in a very objective way in the context of clinical trials. We're also interested in language interventions, and we're obviously also interested in medicine. So we're doing a couple of different clinical trials, and hopefully, if some of the results are promising, we'll be rolling it out to larger studies and doing more sites and doing kind of multi-center trials. Latha just got is it a postdoc or postdoc got funding?
So our site is particularly interested in behavioral and learning interventions and thinking about how we can take what we know and about the mechanisms behind behavioral interventions. There's a strong behavioral sciences, our understanding of how some of these interventions work, and see why they might work or not in Phelan-McDermid. And it starts off at a very basic level, and Ali Weiner, who's here, is a recipient of the PMSF fellowship, and is starting out this area of research and understanding what families are doing, testing out some telehealth-based behavioral interventions. For a lot of reasons, we think that this is going to be, we're optimistic about this approach in rare diseases, particularly Phelan-McDermid. We get reports from families about anxiety, about getting on the way to school or coming into our clinics for the testing. Just this whole sort of novelty of different places that takes longer to see, seem longer to attenuate than maybe in other conditions. This might be one way to approach this idea. And also because families are spread out and the practitioners that are able to do effective interventions are not close by. So the telehealth model is something that Ali is going to be looking at. We're also with Audrey and collaborators in Northwestern just starting to bring in expertise in infant cognition to help us better understand the early sort of ways we can test visual, cognitive, and motor domains and how these link across development. So we are just starting this with collaborators at Northwestern, including Molly Losh's lab, who works in rare diseases related to autism as well.
Yeah. So just building on that, what we really, really want to do is build alternative ways to assess cognitive development, things that, again, you as parents may be seeing with communication and cognition that we just are not able to tap into with the measures we have right now. So that is a long-term goal. At NIH, the other things that we've been doing is just what you heard this morning, tapping into the other medical expertise that exists at NIH to look more deeply into some of the features like the GI issues and the epilepsy and the seizures. So we've been able to do that at NIH so far.
Can I interject something really quickly? Is Ali here? Can Ali stand up? Ali Weiner? Is she out of the room right now? Okay. As Latha mentioned, Ali is the recipient of a fellowship from our foundation. And really, 6 years ago at the last conference in South Carolina, we kind of had a panel of researchers, and we'd ask them, what's it going to take to develop therapeutics for Phelan-McDermid syndrome? And one of the researchers said, an army of researchers. And so we're trying to build that army through training and through supporting young investigators. See things like the poster session as well as initiatives like fellowships. And so Ali is the recipient, and we did that because we feel it's really important to have people who are well-trained in Phelan-McDermid syndrome who are learning about the methods that these more senior investigators are using and can take that and then to help develop new tests more specific to Phelan-McDermid syndrome.
I totally agree, Geraldine. We need, more researchers, physician researchers in this field. So there is one question, and I think I can address this. This is very simple. New families would like to get information about sites, joining the studies, and contact information. You can, of course, get it from our panelists, but you can just Google RDCRN, NIH, and then you will see 22 consortium, and one of them is developmental synaptopathies. And then you will click on PMS, and you will see all the sites and the contact information. We have 4 more minutes, so I'm going to quickly go over 2 questions. And one is, even though Dr. Kolevzon very nicely explained the need for the natural history study, the importance, and I briefly touched on it, we still have a question, and it says, what is the purpose of natural history studies in broader context of research and drug development? Why it is important, and should families get involved? So in another way, and I would just request you, and then I have another question, and I would like comments from all 3 of you.
So it's important because if we want to develop treatments, we need to know how to target those treatments. What kinds of domains do we want to focus our efforts on initially? What the population is. So there are children that are 12 months affected, and there are adults that are affected. So we need to understand the natural history in order to figure out who to include in treatment studies. A lot of times I get asked the question, is it still reasonable to expect change if you treat an adult? The answer, I think we would all believe to be yes, but these are things that we need to understand better. And then also, I think most important, or equally important, is predicting the way that diseases progress helps you figure out how to monitor and how to know what's going to happen next and what kinds of things to be aware of. It's much better if you know that a significant portion of kids develop seizures at a certain age, so that at that age you have a much lower threshold, for example, for doing EEGs. I mean, that's a very basic example of it.
Thank you. And all of us are available, so feel free to touch base with our panelist or me, and we'll be happy to explain why natural history studies are important and why you should participate. So there are 3 or 4 questions on regression. And in the last couple of minutes, I would like to request all 3 of you to give 30-second take on this particular topic. Does regression happen once, or do they see multiple episodes over lifetime? Do they return to previous functional levels? And does adult regression happen because of the schools stopping? And 5 to 6-year-olds are interested in a specific definition of what regression is and what it involves. Are smaller regression considered separate phenomena, or are they connected?
Go ahead. 30 seconds. Audrey, go.
So regression is an awful term, and I hope we stop using it. It came from really bad place, but let's think about this in different ways. So we were already talking about changing the questions on the registry. So there's one thing is just change. It's just change in behavior, and that is not necessarily the same thing as regressions, but it could be becoming more irritable, becoming more labile, and then of course you stop doing the things that you might be doing when you're so irritable that you don't care to do things. You lose motivation. So that's one thing that we're definitely hearing about, and just this is all anecdote. We have no data yet, and this is exactly why we are doing the natural history study. But we are hearing that these things are happening at different ages and sometimes multiple times for people. Then a separate thing is actual skills, loss of skills, and this is something that is in the broader autism literature for sure. And very heavily connected to some other specific genetic disorders like Rett syndrome. It has probably the clearest description and a very sort of more narrow version of this that seems to exist. What we're hearing so far is that this is pretty broad in Phelan-McDermid syndrome. We're hearing the classic, what we thought about of language, we're hearing that, but we're also hearing some of the other areas like daily living skills, toileting, things like that, as well as motor skills. So this is just what we know now.
Thank you, Dr. Surya. Oh, okay.
Oh.
No, I was asking you to.
I mean, I really like this idea of that as a network and as sort of a field where we should be distinguishing between regression and change. And I think our methods for tracking regression are linked to disorders that we know, but we're maybe not doing as well, thinking about how to monitor change. And Geraldine, you had a really nice suggestion at our table about possibilities of using the types of monitoring that we do in psychiatric and other conditions to monitor change through sort of parent-reported electronic input. So anyway, just to echo that, I think that's something that we could work on.
Thank you.
Yeah, and this goes back to the idea of natural history studies. If the way that PMS presents changes over time, or if there's a particular domain that we know is susceptible to change, that may not be the best domain to target in a treatment trial because, again, it's changing, so it makes it very complicated for us. And the other thing I guess I'll just mention, because I agree with everything that's been said, sometimes I think from a parent's perspective, there's a plateau where a child might be gaining some words or using some words and then stops getting additional words. And that doesn't actually, for us anyway, qualify as necessarily a regression. There could just simply be a plateau. So that could raise all kinds of concerns where you expect your child to continue to develop, and there's a little bit of a flattening, and that happens with development as it is, right? There's just change is much more rapid when children are younger.
So thank you. There is a question that I should repeat the website. So what I said was, if you go on Google or any search engine and type in RDCRN for Rare Diseases Clinical Research Network, NIH, a website will pop up. Then you click on consortia. And one of the consortium is, and what I'll do is I'll send the link to Geraldine and then she can distribute. How about that? And I apologize, there were a few more questions. We were not able to address those, but the panelists are here. So feel free to contact them. And about the award cycle, when the next, specifically for RDCRN, and there are other opportunities within NIH. Maybe next time I'll give a short talk on resources at NIH. And that will be an open competition, which means this group can again apply and put in their application for competition. So I guess I'll stop here, and a big round of applause for our panelists. Thank you.
Many thanks to our panel. This is yet another topic where I feel like we need at least another hour to even begin to scratch the surface.